Hello and welcome to Newsnight, where we speak to major league players in Nigeria's democracy and the issues generated from its drive for growth and development. I'm Ladi Akiridoluale. Thanks for joining us. The recent emergence of two health crises, Lassa fever and the coronavirus, put the spotlight on Nigeria's healthcare system. How is the sector faring and what are its challenges and prospects? My guest is the Minister of Health, Dr. Osiage Ehanire. Honorable Minister, thank you very much for your time. I know this is a busy time for you, but thank you for making our time.
And thank you for inviting me.
Now, let's start from the most current of the events and what is being done. Let me start off with our situation with Lassa fever. The last I heard, it had gone to a number of states beyond those that were traditionally its hangouts. And people are getting a bit worried about what's happening and what's to be done about it. Where are we with that?
Well, where we are is that is a better understanding of Lassa fever. We know the vector, which is a rodent. We know that it's a virus. We know it belongs to the family of viral hemorrhagic fevers. And what is also coming up is that the case fatality rate is dropping, because knowing it, we are now better able to handle the treatment. And where the fatality was just a couple of years ago, 30%, fatality rate is now 15%. And for some reason, the epicenters are in Ondo, Edo, and Ebonyi, and sporadic appearances in other states.
Now, having said that, are we having a policy to attend to this now? Because in the case of Ondo, for example, that you mentioned, I know for a fact from personal experience, it keeps reoccurring almost on a yearly basis in that state. So I'm wondering if it's not something that maybe we should have a policy to attend to, since it seems to be a recurring event.
Yes, it's correct. It's endemic, let's put it that way. And endemic means that it's actually there all year round, but it peaks during the dry season. And the peak is suspected and believed to be because rats and rodents, finding no food in the bush, begin to invade houses, and they somehow get access to food and leave their droppings and urine and so on food that's left unprotected. And so the cases mount during that period of dry season, and it's much more frequent than you see during the rainy season. But there is a lot of study going on. We have virologists and other experts who are looking at what is going on with the large-scale cases that we see during the dry season. And there's also vaccines being developed against it as we speak.
Now, having said that much, it then brings me to the issue of what's causing this. You've talked about what's being done, to mitigate the circumstances in which it now is in existence. But some of those I had spoken to, not necessarily medical personnel, point to a link between it and the issue of hygiene, general hygiene. Is that correct?
You are perfectly correct, because hygiene and also some certain social behaviors and sanitation play a very big role. If you have rodents invading your house, obviously you have a problem of hygiene and sanitation. The rats should not be able to enter anybody's house easily, and even if they manage to get in, they should not be able to have access to your food. So yes, hygiene, personal hygiene, food hygiene, and domestic hygiene, environmental sanitation play a big role in this disease pattern.
Now, you at the tail end of your previous answer before this last one, you talked about a vaccine. And a lot of people's hearts would leap with hope when you talk about that, because that seems to be a far more effective method in that case of prevention rather than cure.
That's correct. There's a vaccine being developed for it. It's still some way away from being used, but trials have started with it. It is being worked on at the Premier Hospital where Lassa is treated. That is at the Federal Teaching Hospital, Irua. And there is hope that in some years we shall be able to have a vaccine against Lassa.
Now, given the fact that a lot of people come in direct, a lot of those who eventually are victims come in direct contact with medical personnel, do the medical personnel have exposure to this in any way?
Yes, this is also a disease that has a lot of human-to-human transmission, apart from being animal to human. So the importance of personal protective equipment is very, very highly written for those who work in treatment centers. You know that Lassa is treated in special infection areas in the hospitals designated to treat it, and the workers there have to follow very strict protocol on personal protective equipment.
How far have this gone? Because just a couple of days ago, it seemed as if some of the medical personnel, in view of this issue, were asking for all kinds of provisions to be made for them, special allowances and all of that. How was the link between that and this? If they are under the strict protocol you talk about, I don't know if there's a link between the two. Do they really need to be treated specially for this kind of... You're a doctor, so I mean...
Well, yes. Well, you see, the standard protocol for handling patients is very well known, but what you're handling infectious cases is a different protocol. And more often than not, when patients come in to see a doctor, the doctor is not immediately thinking that it's an infectious disease until other signs begin to show up. So if you look at what happened in Kano the other day, when young doctors there who were busy doing their work saw a patient who they thought required cesarean section, obstetric case, and their mind didn't go to the fact that the patient could be infected. So they became unfortunately infected from performing that operation on the patient.
Now, the other big thing that is currently going on is the coronavirus, which is international. As at the time we're speaking with you, of course, there isn't any confirmed case of this in country. But we hear that there are measures being put in place to make that be the continuing situation, that it doesn't come in. Can you enlighten us on that?
Yeah, very good. We want to keep corona out of Nigeria. That is our mandate, and we are really watching out for that. The first area of defense is the airport. We believe that the airports are the only feasible ports of entry at the moment. Seaports and land borders are extremely unlikely in this particular case. So we are reinforcing our air entry points. International airports in Nigeria, there are 5. Lagos being the largest, followed by Abuja and Port Harcourt. And protocols have been set up there to scan every passenger who comes in and then invite anyone who is not looking too well for an interview where we take the travel history and learn where he has been to. If we have reason for suspicion, he's not looking too well, he will immediately be tested. We acquire the reagents for testing the coronavirus in country, so we can do the test now. We don't have to send samples out. And if the patient does not look sick, looks very well, they will be put on what we call self-isolation. They go to their homes and then leave their phone number. We also give them a number to call, and they call us within a period of 14 days to let us know that they are fine. And if they do not call, we call them to make sure that within that purported incubation period that they are well, and if after that they can go about their business.
Now, that speaks to the issue of self-quarantine.
Well, I wouldn't call it quarantine exactly. I call it isolation, in that if you come from a place that has a particular disease, you keep yourself away from people, keep away from the public, don't go in any crowded place, don't go in any bus. In fact, within your home, you keep away from your children so that you don't run the risk of passing this infection on to them. So the point in that is that the patient does not need to be held in the hospital but can keep himself away during the period when this germ could manifest. Now, in many cases, it doesn't manifest, and if it does, we'll catch it immediately.
Now, moving away from those current challenges and now to the broader issues, there is the issue of primary health care. Even when things like this happen, people present themselves mostly, especially those who are not in the urban centers. They present themselves at primary health care centers
Yes.
in the semi-rural or rural areas. As things stand today, how well prepared are those centers, not just for this kind of things, but for other ailments that may afflict people and which, if not properly treated or controlled, could spread?
Yeah, primary health care is very central to this administration's health program. And because it is the area where you are able to attend to the largest number of people and take care of the largest disease burdens, which occur at the very basic level. If we have a functional, very functional primary health care system, we believe we shall take care of 50 to 60% of the entire disease burden that plagues our country. We shall reduce maternal mortality, infant mortality, under 5 mortality, and Nigeria will be much better off with her indices. But the primary health care structure needs to be set up, and we are in that process. As of the moment, about 40% of them are functional. And we have also, in fact, changed the design in that we want primary health care centers that work round the clock, and not just from 8 till 3. And that means providing light, providing water, and then providing a complement of staff with staff quarters that can go on shift. So with that, you can be able to attend to patients when they are sick and when they need help, and create a supply chain that allows you to give them all the things they need to operate with. So primary health care is written very big. It will reduce the pressure on the tertiary hospitals, and we also need to follow up by building the secondary health care system, which at the moment is not in very good shape, but which obviously is an important next step after primary health care.
What does the secondary healthcare system comprise of?
The secondary healthcare system comprises of general hospitals, or what some might call comprehensive health centers, of which we are looking for at least one in every local government. You can have many in local governments, but they have a catchment area of a certain number of primary healthcare centers who refer cases to them. And at the secondary level, you have family health practitioners, you have doctors, whereas the primary health care center may not necessarily have a doctor, may have a nurse, or may have community health workers. But the secondary health care center will have a doctor, or doctors, may have specialists like pediatricians and internists and surgeons, and they'll be able to take care of many of the middle level cases that normally will be flowing to the tertiary institutions.
Now, you mentioned earlier that the tertiary institutions are put under pressure because these first two seem to not be in perfect condition yet. And therefore, those tertiary health institutions who should see only specialized cases that the first two can handle are now under pressure. Everybody seems to head off in the general direction of the tertiary health.
That is correct.
How are those centers now? Since that's where most people end up anyway, given the current system.
Yes, that is true. They are under pressure. They do have to do a lot of outpatients, a lot of cases which didn't need to go there in the first place. So if that pressure were off, they will be able to focus more on providing what is actually known as tertiary care. Obviously, a little bit of secondary and primary care. We're not saying that they should be totally cut off from that level, but that the volume is reduced for them to be able to focus resources and human and material resources to more advanced care.
Now, how has that worked out? Because it does seem as if the federal government has focused a great deal of attention on the tertiary healthcare centers.
No, that was in the past. In the past, we seemed to have understood healthcare to mean large hospitals that are visible in big cities, and primary healthcare was ignored. And so a lot of the horrible indices we hear in Nigeria today came from the rural areas and suburban areas where they had no care. And anybody who had enough money and was sick and could afford it will have to find their way to tertiary health care. So that is why it looked as if in the past, you are correct that a lot of investment was on tertiary health care. But a balance is being created now by this administration to put more focus on primary health care and also encourage the state governments to focus on secondary health care, because the tiered system of health administration of health service puts the secondary health care actually in the purview of state governments. But even if the secondary health care doesn't work, there's pressure on the tertiary side. So if you have a more balanced investment, primary health care will improve, and we are hoping that well-intentioned groups will join in investing in primary health care, and they will restructure secondary health care and have a normal functioning national health system.
Now, some of what you said, am I right to assume that it's part of a national health plan which the government is pursuing, and that I'm just picking bits of it to which you are answering?
You are correct. You are correct in thinking that way, in that we look at the health system that is divided into what you might call basic or primary health care, which is available, is ubiquitous, people can reach it and get it when they want, and takes care of the majority of cases. A lot of what is done there is also education on hygiene, sanitation that we already spoke of. It's also education on nutrition, on home care, baby care, infant care, environment, and it's also a platform for delivering vaccination. So if you're able to do all of that at that level, you've taken care of waterborne diseases, you've taken care of vaccine-preventable diseases, you take care of diseases from sanitation, and you're able to take care of vector-borne diseases also. So that helps to relieve pressure generally on the entire system. But the system actually sees that layer of attention as a purview of local government. And then the secondary health care is largely purview of the state government, and the tertiary is a purview of the federal. But because the first two are not doing very well, the federal has to invest in the primary health care to support that primary health care. And that is what led to the National Health Act, and also the Basic Healthcare Provision Fund, which is supposed to support service provision at primary healthcare level.
Now, what are the other parts of the National Healthcare Act?
Well, there are other parts that have to do with the private sector, because the private sectors play a very powerful and important role in the entire health system, because they provide service from primary to secondary to tertiary level. And
in competition with the governments?
Not in competition, let us say supplementary, in the sense that they are filling a lot of the gaps that will have made the health sector look probably even more difficult than it looks now. And in fact, they fill up a lot of the gaps at the secondary healthcare level, where the general hospitals are either not functional or not available. So the secondary healthcare is occupied by or provided by doctors with their hospitals, 10, 20, 30, 40 beds, are able to do cesarean section, appendix, hernia. They're able to take care of pediatric cases. So they fill in that gap. And without that service, things will not be looking as good as, not that they look too good now, but they will be looking worse.
Worse. Now, let me then ask about the linkages, as it were. And now, you've mentioned it twice in your answers, where you talk about personnel. Now, it's obvious that in terms of the health sector, we don't have enough personnel as per our population. And then that brings the question of, is there a deliberate effort? Is it part, for example, of this Healthcare Act to deliberately encourage the production of more of this medical personnel? Because even if at the end of the day, the institutions are built, the buildings are put in place, the equipment and so on, you're still going to need these people.
Yes.
to man those institutions.
Yes. You are correct in that we have challenges with personnel. It's a double-edged sword. We are training many people, but we have issues in that many are not being employed at the levels where they should be employed. I just told you now that the secondary healthcare level is not doing too well. And part of the reason is that there is no personnel and the facilities are not all prepared to give service, or not sufficiently prepared. And the personnel which are required are also not being employed. Even at primary healthcare level, the employment of community health workers and nurses is not too good. Many of the states say that where their health bill is already too high, and the result is that we have some attrition in that a lot of our health workforce is emigrating. So you train personnel and they emigrate.
And take away those skills with them.
Not only take away the skills, the cost of training is a lot. It's a lot of money. We pay for that. The state pays for much of the training or subsidizes it. And once they graduate, they go outside the country. So you're actually rendering, without knowing it, development aid to certain countries, in that you are supplying them with skilled personnel, highly skilled, highly trained personnel, where you yourself are not being able to actually meet your own needs. So it's a bit of an odd situation we have in there.
Now, again, speaking about the National Healthcare Plan, there was also always the issue of funding. The healthcare sector is very capital intensive. It requires quite a lot of money. Some people would say that there are standards by which this should be measured. Percentages of the budget should go to the health sector and all of that. But in reality, most people know that that is not really possible, especially for economies like ours. But in terms of funding, you mentioned the private sector earlier. I'm wondering if there is anything in the National Healthcare Act or that the ministry is thinking of on behalf of the federal government in order to improve access to funding so that quite a number of the things you've mentioned need to be done don't have to be provided by the federal government itself.
That is true. The health system requires government investment, but also needs to be able to have a mechanism for financing or partially financing itself. And that's where the National Health Insurance Scheme comes in. Now, the insurance scheme created some years ago catered only to the first of all to the civil service, public service, and to the formal sector. Now there are considerations to expand coverage and make it compulsory, make it mandatory for everybody to have a health insurance, so as you can have a pool of resources which can drive the health sector. And we are working on that right now. We are talking with the National Health Insurance Scheme is under this ministry. We are having conversations on how to create new models that will generate the funding. So the funding drives the health sector. But we also have issues apart from that. We have issues of governance. Governance needs to be probably reformed. We need to reform our governance structure.
How?
Well, you need to bring in more efficiency. You spoke just now about shortage of personnel. Yeah, the paradox is that you find that in some of our hospitals you have a large number of personnel in some areas, more than you need, and some other areas you don't have enough. So you have a sort of imbalance where you don't have enough of critical staff, and then you have very many of the non-critical staff. So it's sort of an imbalance in there, which needs to be corrected. That does not mean that anybody will be retrenched, but there's a reorganization has to take place that makes everybody useful and also relieve the imbalance we have in the system.
Now, you talked about personnel and so on, and then you mentioned the issue of states. One thing that seems to reoccur is that when various medical personnel ask for help or improvement in their welfare positions and so on, the federal government usually is able to meet up with its own personnel. Then you find that the demands percolate down to the level of the states and the local governments, and those ones simply throw their arms in the sky and say, we are not the federal government, we can't do this.
Yes.
Leading to some levels of industrial strife at that level. What is the state now? And what do you think can be done to avoid this? You're a doctor, and they say the doctors are at the top of the food chain in the health sector. So, looking down from up, how do you think this can be addressed?
Well, I spoke of governance just
Yes.
now. We need to reform governance structure. The way it is, there are some states that are wealthy enough to be able to take care, or at least to a good extent, take care of a lot of their health needs. Lagos State, for example, they are very well off, and they're able to achieve their dreams, make plans, and achieve their dreams. Many other states are not able to do that. They do not have the resources, and they do not set the priority in the same way that we look at it. So again, that affects the issue of governance. How do you run your hospital? How do you get the best out of your workers with the limited resources you have? How do you improve productivity? Because if you find a place where everybody is paid the same no matter what you do, then there are some people who work very hard and others who don't want to work hard. And if you're all paid the same, there's no incentive. So in reality, if you're able to devise a mechanism by which people work very hard are also paid very well, it will encourage those who are not working very hard to start working hard. And in the professions, it's always like that.
Now, let me bring you to something else that is equally contentious. Medications. Many of Nigeria's medications, or medications that are used in Nigeria, are imported. And that then imposes some kinds of challenges on the usage, costs, and other such things. I know that the federal government set up like a central system by which it does bulk purchases at some point of some of the most basic of the medications so that they remain at the level at which most people can take them. Are you hoping to expand the scope of that to include other things which may be a bit more specialized, but which quite a number of people utilize? I'll give you an example. For example, in HIV/AIDS, for example, more and more people antiretroviral drugs. I don't know what the situation is with that.
Well, we are depending on domestic manufacturing. The pharmaceutical industry is alive and well in Nigeria, and they need encouragement, they need support. We need to be able to procure from them and encourage them to expand. So it is only in that area that you find the expansion. Government itself does not run any factories for medicines. And if you have pharmaceutical companies that do that, and you have a regulatory system on hand, then you know what you are getting. Now, the problem you're alluding to of drugs that are not standard are the drugs that are coming illegally. Drugs that are coming illegally are tested by NAFDAC, but there are others that slip by through uncontrolled borders and enter the market. So you need to police all those areas and make sure those drugs are coming. But by and large, the government wants to encourage the pharmaceutical industry, nearly all in private hands, to develop and grow. And we have been able to collaborate with some companies in trying to produce vaccines domestically. So, and we have research organizations here that have also developed one or two new products that can be put on the market, manufactured locally and put on the market. But so long as these medicines are tried and tested and they are efficacious, we can use them here. But if you are going to export, you have to have WHO pre-qualification. As a matter of fact, if other companies are going to buy from your development partners are going to buy for you from us, they will ask for WHO pre-qualification from these companies, and only a few have this pre-qualification.
Now, from a professional standpoint, people talk about generic drugs as opposed to trademarked medications, and there's been this whole debate about the efficacy of generic drugs vis-a-vis those that are sold or marketed and produced by those who originally came up with the medications. What's your own position on it?
Well, the most important thing in any drug is what you call the active pharmaceutical ingredient, the API. That is the most important thing. So if you have the API, the others are just to create a background for the pill or for the syrup. So if you have the correct quantity and quality of active pharmaceutical ingredient, you are okay. Now, the job of NAFDAC is to test that a particular medication that you get has that active pharmaceutical ingredient and has it in the dose which the package says it has it. Now, whether it is branded by one big company or not branded is a different matter, because the branded one, which the company puts its name behind, usually is more expensive. The unbranded ones that go by common names or the generic name is cheaper generally. But if they are well tested, they do the same thing.
Yeah, because a lot of people, especially in our own system here, tend to equate cost of medications
With quality.
With the quality.
Yes.
And that was why I was asking about your own, from a professional standpoint.
Not necessarily so, because the active pharmaceutical ingredient is what matters, and if both medicines have been actually tested and contain the active pharmaceutical ingredient, the API, and they also contain it in the correct dose, then you are well. In all developed countries, you have the same thing. In the United States, you also have generic drugs. In the UK, which are not branded, which are cheaper, which the common man can buy, while those who insist on branded medicines can also have what they want. But the drugs, by and large, will do the same thing.
Now, at the place where we are now, with in the country now, control of diseases, prevention of diseases, people will tell you, people like you will tell us that prevention is better than cure, which goes back to primary healthcare, which you talked about earlier. And the fact, I remember in the 1980s, the late Professor Oliko Iransom-Kuti had a program where he focused on little things that people could do to prevent from ending up with problems that could then prove fatal. The salt and sugar solution with child diarrhea and things like that. Now, a lot of people talk today and they say that, look, attempting to cure anything now is extremely expensive, apart from the fact that 50-50 usually with diseases once you have them. Is the federal government thinking along the lines of reintroducing this kind of awareness, development programs and so on, especially at that level, to ensure that some of these things need not come to your attention for answers if people already know how to deal with them?
Yes. Well, if you remember what I said at the beginning, that much of what will go on at primary healthcare level is education. And that education goes with awareness creation, with being brought into the knowledge that what you eat matters and how you eat it matters. And a good part of that is hygiene, food hygiene, that you prepare your food correctly, and then you also know the right food to give, nutrition. There's malnutrition in some places, not because they don't have the food, but they give the wrong ones and they don't give the right things. So education takes care of that. And if you're able to build up your education sector, either from school, that's why the Ministry of Education is also important, or also working with the Ministry of Women Affairs, because in most homes, healthcare is in the hands of the mother of the woman. So working with the Ministry of Women Affairs, we can create a lot of enlightenment that is able to help to prevent diseases. The big point of our primary health care is disease prevention and health promotion. Disease prevention and health promotion, and if you cap that with a good vaccination program, you have taken care of 50 to 60% of your disease burden.
Now, the vaccination that you mentioned last, there are a number of things that, or there are a number of ailments that ought not to trouble health authorities if the vaccination process was complete, the coverage was total, and so on. But some of those things still reoccur because in some cases it's cultural, in some cases it's attitudinal, in some other instances it's because logistics prevents you from being able to completely cover all the areas that need to be covered. Where are we with that? What's the status of that?
Well, there's been a lot of improvement. The immunization coverage now has gone from about 30% to 55% or something like that. So there is a lot of improvement. But you're also fighting with the concept of people not understanding what it is. So you also find situations where rumors go around that convince people that immunization is dangerous, that it will make you sterile, or it's meant to reduce your health. So those are things which you are fighting with all the time. We work with community leaders, with traditional rulers and religious leaders to improve the uptake in immunization so that you are able to have, we are gunning for 80% coverage within the next few years. And it costs some money, but and also increasing the panel of antigens, of things, of diseases you immunize against, so that you cover many more potential dangerous diseases.
Now, international support. A lot of these things that you talk about, health is one area where there seems to be increased collaboration internationally. If not for any other reason, but for the fact that these ailments can move from one area to the other very quickly. How is that going? How much international support is the ministry getting, is the federal government getting in the healthcare sector, and in what areas?
Yeah, we get quite a bit of support, and there are countries who, as you say, are very much interested in controlling particularly dangerous diseases so that they don't spread around the world. Those are the ones of global health concern. Just the other day, the World Health Organization declared the coronavirus a public health emergency of international concern because it's capable of flying around to different parts of the world carried by humans. Mm-hmm. So we do get support. Most of the technical support we get is from the World Health Organization, and they study global health, and they give support to countries that require support, technical, sometimes even financial support. So there are other philanthropists and groups and international NGOs that give support. We can't mention all of them right now, but there are the various UN agencies like UNICEF and so on, which also join in helping us. Bill and Melinda Gates Foundation, Dangote Foundation, T.Y. Danjuma Foundation. So there are many Nigerians who are also coming into the sphere to support the government's work of improving health, particularly public health, improving public security, public health security.
Now, as we wind this down, I want you to update us on some of the others. You see, at this point in time, it appears as if a lot of attention is being focused because while we're dealing with Lassa fever locally, we're dealing with coronavirus internationally. So a lot of attention. But once that tends to die down, more or less it will be back to business as usual. While the attention is focused on the health sector, what other ailments are being identified by your ministry and the government as areas where there's need to take effort to tackle now?
Well, the areas of concern, apart from the ones you have mentioned, are first of all the neglected tropical diseases. Those are the old diseases that were found around here, which are the diseases that bother poor people: elephantiasis, sleeping sickness, and so on. Then there are the new ones that concern us a lot, the non-communicable diseases that come around with hypertension, heart problems, renal problems, kidney problems, and cancers. So those diseases are extremely difficult to treat. They are stubborn, and a lot of them are connected with lifestyle, consumption of excessive salt and sugar, consumption of processed food. So we are talking about returning to natural food, to the way we used to eat, in fact, a lot of countries in Europe and America who used to fancy processed food are moving away. They are going to what they call organic food,
Indeed.
which is better, more nourishing, and less presumed to be less hazardous, reducing sugar intake, particularly after a certain age, watching the kind of oil you use to take care of your threat of cholesterol excesses, and reducing your salt. And also, we are being advised, do some exercises, keep yourself active, and make sure you sleep well enough, and eat a lot of vegetables and fruits, and have a more positive attitude to life. So that's what we call health promotion, and it is a failure of that particular area that sees the increase in non-communicable diseases, and those are the ones that finally require people to go and be looking for kidney transplant, or looking for heart trouble, heart transplant, or even interventional cardiology, and heart attacks, which are increasing, said to be increasing in Nigeria, or the various forms of cancer, which are also being studied as we speak, because the incidence in some areas seems to be increasing, probably linked to food.
Now, the alternative that many people seem to have taken up is herbal medicine at this end of the spectrum. Those who don't have the resources or maybe the information to pursue the traditional Western options to treatment seem to go to herbal medicine because that appears to be cheaper and in some cases quite effective. What's your view about that, about traditional medicine or herbal medicine as it's called, as part of the options that are available for healthcare?
Well, let me say that medicine is one. And what we do is what we call orthodox medicine. It is school medicine, it's structured, and it is organized. Then the other is traditional medicine. And the traditional medicine is all we had before orthodox medicine came about. And even the European countries today, everybody started from traditional medicine to where we are now. Now, a good part of traditional medicine is herbal medicine, as you said, and it needs to be better understood. We have a research institute called the Institute of Pharmaceutical Research, which takes a lot of interest in research of herbal and pharmaceutical and plant medicines. So, up till now, they have already discovered some things that are used for sickle cell treatment, for example. But again, there's a lot to learn. There are so many plants in Nigeria. Some of them have medicinal value. There are some that have no value at all, and there are others that are in fact toxic. So you have to know what you are doing, know what you are taking. That's why I say that there is a lot of work to be done there.
In introducing structure.
Introducing structure and differentiating what works and what does not work. And not relying too much on anecdotal evidence. You need scientific evidence now, and it's going to be coming into traditional medicine. But so long as the patient gets well, fine. If you feel you are well, that's okay. So whichever way it takes. But the one form of medicine, particularly traditional, that is not even herbal, but that is more psychological approach. If it works, fine. But there should be no delay in seeking real help if that form does not work.
Now that brings up the issue of the what people call alternative healthcare.
Yes.
I don't know what the ministry or government is doing on that. What I mean, I know you understand what I mean by alternative healthcare. I know what you mean.
Yeah, we have a department of traditional medicine here. We have a department of traditional, complementary, and alternative medicine here in the ministry, and they are doing a lot of research. We are establishing a school for it. We are thinking about a school for it. We used to have one. We are in fact reviving it. But again, a lot of research is necessary. There is a lot that is not yet known about the values. There is value in there, but the purpose is to find the value and to know what works for us. That's what our forefathers used. But
and some would argue that they lived for much longer than we are living.
Well, not necessarily, because life expectancy is actually increasing now. It used to be more shorter, but life expectancy is improving, and obviously due to better care and improved knowledge about health, about the body, and about medicines. There's a big role for traditional and alternative medicine. Some of them address the psyche, they address your mind, which is also good. There's nothing wrong with that, because psychotherapy is part of medicine too. Some address your state of mind, your not necessarily what is physical. And others are able to have contents that are not yet fully understood, which need to be researched. And there are some that are of not much use.
Honorable Minister, 2020. What do you want to see at the end of 2020 as the Minister of Health?
Well, at the end of 2020, there's a lot I want to see. I want to see a huge move towards developing a primary healthcare network. And I want to see progress in developing the health insurance scheme, that is to say the health financing. I want to see an improvement in the human resources for health, an improvement in healthcare delivery, and I want to see the secondary healthcare structure begin to be resuscitated. I want to see a good link between all these three. I also want to see an emergency medical service established in this country, the type that if you have a problem at any time of night, you can call and they come to you instead of being left to yourself and waiting till the next day, which they might not even reach. So an emergency medical system that we are working on also here in this ministry, that will have a system, an ambulance network that will either come to someone who's had an accident, or someone who's gravely ill, or someone who's a lady who's going to deliver and can't deliver or has complications after home delivery, and be able to do first aid and take that person to the hospital for care, and guaranteed, whether they have no money or not, whether they have money or no money, guaranteed that they will get treatment.
Honorable Minister, thank you very much for your time.
Thank you very much for your interview.
That's today's episode of Newsnight. Do let us know what you think of the conversation. The handles are right there on your screen. I'm Ladi Akeredoluale. Thanks for joining us, and goodbye.